Hello, I'd like to welcome you to the Go Diabetes webinar on smoking cessation. As participants, your phones have been muted. We do have a process for getting questions using the chat function. If you'll, as you hear or come up with a question as we're going along, please go to the all panelists, send to all panelists, and then type your question underneath that, and we'll be able to respond to those at the end of the presentation. I would like to tell you that this webinar is being recorded and will be available within a week on the Go Diabetes website in case you have colleagues that want to listen to it. At this point in time, I'd like to introduce Dr. Margaret Crossman, who is our faculty for today. She is one of our returning lead faculty for the Go Diabetes project. And Dr. Crossman is a Florida girl born and bred. She did all of her education in Florida and residency and is currently an assistant professor of medicine at the Florida State University College of Medicine and on the faculty at the Halifax Hospital Family Medical Residency Program. She is the Women's Health Coordinator, and she has an interesting perspective in the fact that she has worked in private practice and in academic medicine as well. She has a special interest in working with women's health issues. But she's going to share today her knowledge on tobacco cessation, tips of the trade. Dr. Crossman?
Thank you, Susan. I'm glad to be here. It's really a privilege to be talking with you about a topic that all of us are dealing with probably on a fairly regular basis, and probably not just in our offices, but perhaps our families, maybe even friends have been touched by this problem. So certainly it's one of the things we want to focus on in our management with diabetic patients, and so we're going to go ahead and get started and hopefully walk away with some tips of the trade taking care of our tobacco smoking patients. So the goals of our talk today are, I want to make sure that we all understand the problem of tobacco use and dependence and hopefully become better equipped with the tools we need to address the epidemic. And we certainly want to be able to better encourage and empower our tobacco users within our practices to quit, and not only for a short time, but certainly for good. So just to review the scope of the problem, you know, globally use of tobacco products is increasing, although it's been decreasing in high-income countries. We know that tobacco use is one of the biggest public health threats we've ever faced. There are more than 1 billion smokers in the world. Now, granted, there are other big health threats, but this is very, very broad. Tobacco use kills over 5 million people a year. An average of 1 person every 6 seconds dies as a result of this. And tobacco kills up to half of all of its users. We know that it's a risk factor for diseases such as cancer, MI, stroke, COPD. So let's look at how we're doing here in the United States. Cigarette smoking, we know, is the leading cause of preventable death. We've got 46 million adults smoking in our country by our best estimates. We run at about 21% prevalence, men at 23, women at 17, for an average about 21% prevalence of adults smoking tobacco in this country. And we have about 1 out of every 5 of our deaths each year that are attributable to tobacco. When we look at the country as a whole, we see that the Midwest and the Southeast regions are where some of the heavier use is occurring. And additionally, by our best estimates, 70% of these smokers in our country want to quit. And almost half of them tried to quit in the past year. You know, sadly, the 1-year abstinent rate after a quit attempt, and we'll specifically say an unaided quit attempt, that's where someone's just trying to quit cold turkey, is less than 10%, somewhere in the estimate of maybe even 5 to 8% at a year. Now, the good news, well, there's good and bad news. This can exceed 30% with optimal treatment. The bad news being that only 25% of smokers who try to quit are seeking our help. So to facilitate providers, the United States Public Health Services has come up with some clinical practice guidelines, and this should help guide us. It was derived from experts who got together to identify effective, experimentally validated tobacco dependency treatments and practices. Now, the most recent update, and the one we'll be going through, was completed in 2008, and it reflects literature current to 2007 along with expert opinion at that time. So the following slides are going to highlight those 10 key guideline recommendations along with a little additional and updated information that I thought would be helpful for all of us. Let's start with the first clinical practice guideline that says tobacco dependence is a chronic disease often requiring repeated intervention and multiple attempts to quit. However, effective treatment does exist, and it can significantly increase rates of long-term abstinence by as much as 2 to 3 times. So for those cold turkey quits that we alluded to earlier, what's the nature of those quits? Well, usually it's one of these 3 things. Someone says, I just woke up and quit one day, or perhaps it was an illness that caused them to have to quit for a time, and they just successfully were able to abstain. There are some of the cases where an MD gave an ultimatum regarding a patient's health, and someone had a successful quit after that. But due to the sheer volume of patients making unaided quit attempts, even though they're not very effective per quit attempt, still these cold turkey quits are going to account for the great majority of actual successes, and this is according to the American Cancer Society statistics. Clinical practice guideline tells us that it is essential that we in the medical delivery system consistently identify and document tobacco use status, and that we treat every tobacco user that we see. We know that health information technology, electronic health records, and all this talk about meaningful use is going to advance tobacco cessation in our country, and partly because hospitals and many providers are, if they're to participate in this incentive program, they're going to be required to record the smoking status for all patients that are 13 and older. And this is what our initial meaningful use core measures are looking like. In fact, tobacco cessation is measure 9 of the 15 core measures. And in stage 1, what they're basically asking is that we record smoking status for patients 13 and older. And to meet this, the way they're going to measure this is to make sure that at least 50% of all of our patients 13 years and older have smoking status that is recorded as structured data within the electronic health record. So we can't treat them unless we identify them basically as what we're thinking here. Practice guideline number 3 says that tobacco dependence treatments are effective across a broad range of populations, and that we should encourage every patient who's willing to make a quit attempt to use counseling treatments and medications that have been shown to be effective. Now, I will add that some safety concerns have arisen regarding some of the treatments we're going to discuss, and we'll discuss that as well. So it's critical for us to stay up to date as we consider and apply these guidelines to our patient populations. And we want to continue refining their application. For instance, there are specific populations, such as pregnancy, where there are increased stakes, at least in the immediate future. For instance, spontaneous pregnancy loss, preterm delivery, low birth weights, PPROM, placenta previas, and abruptions and stillbirths, all of these can be reduced by smoking cessation, and what an impact on our economy that could have. The benefits of tobacco cessation are good at any time in the pregnancy, but the earlier the better. Interestingly, in pregnancy, we know that even reducing the number of cigarettes is going to be beneficial in the immediate future for mom and baby. We have tailored messages we can give to our moms. We can tell them that there's an increased rate of SIDS. We can talk to them about the complications of smoking in pregnancy. So we want to tailor our message to these patients. And as far as pharmacotherapy, you know, that's a little controversial, but the thought is that pharmacotherapy can be considered for women who are very heavy smokers and absolutely unable to quit unaided. Further studies are really needed to evaluate the safety and efficacy of the pharmacotherapy. However, in the USPSTF, the United States Preventive Services Task Force, found inadequate evidence most recently to evaluate the safety and efficacy of pharmacotherapy in pregnancy. So be cautious if you consider pharmacotherapy in your pregnant patients. And this is the sort of thing that we need to go to our guidelines and review and refresh and look at updated literature for as we're caring for our specific populations for tobacco cessation. So it's important for us to understand some of the barriers our patients may have, barriers to quitting. For instance, the addictiveness of nicotine is the primary barrier. It is a potent psychoactive drug capable of causing physical dependence and tolerance. The withdrawal symptoms are very unpleasant and include dysphoria, depression, insomnia, irritability, anxiety, inattentiveness, restlessness, increased appetite and weight gain, which is something that many of our patients struggle with and are concerned about. So there's a lot of people, a lot of reason to avoid the quitting cycle. Conditioning and triggers are another problem. For instance, a smoker may have environmental triggers such as their morning coffee if they smoke with their alcoholic drink or right at the end of a meal or other activities, and those events then become the trigger to smoke, and they compound the problem and the difficulty smokers have in remaining abstinent from nicotine. So one of the things that big questions that we have is, how can we help our patients, first of all, desire, and then, of course, successfully overcome these and other barriers? So desire to quit, and then how can they successfully overcome? And this would be a great question. If any of you see the chat box in this session and you'd like to start typing in some tips for success or share your experiences and how you've been able to help your patients overcome barriers, now would be a great time to put some of those thoughts and ideas in to share with the rest of us. Practice guideline number 4, once they're ready to quit, we know that brief tobacco dependence treatment is very effective. At a minimum, we should offer our tobacco-using patients short-term evidence-based treatments that will increase their chances for success for any given quit attempt. Let's talk about practice guideline number 5. It reminds us that many forms of counseling are effective, and their effectiveness increases with treatment intensity. 2 of the components of counseling that are really effective will be practical counseling, where we help our patients problem solve, and then giving social support as a part of our treatment. We know that we have limited resources at times in some of our practices, and it's heartening to know that the USPSTF found convincing evidence that even brief behavioral counseling, less than 10 minutes, combined with pharmacotherapy delivered in a primary care setting, is effective in increasing the proportion of patients who successfully quit smoking and remain abstinent at 1 year. And although considered a little less effective than longer interventions, even minimal interventions such as counseling for less than 3 minutes have been found to increase quit rates. So let's review some of the tips on behavioral counseling. And as I said, whether it's given in person or on the telephone or through web and other computer-based options, these are all considered fairly effective and definitely fair game. Even brief interventions, again, that can be delivered in medical practices are of benefit. The Public Health Services Guideline developed a simple 5-step algorithm called the 5 A's to help us counsel our patients. And they are ask, advise, assess, assist, arrange. Let's look a little more closely at each one of these. So you want to implement an office-wide system that assures that every patient at every clinic visit you have assessed tobacco use status and documented it. Now, you don't have to continually reassess. This is not necessarily in a case of an adult who's never used tobacco or hasn't used tobacco for many years. So once you've documented for that patient, you would not need to continue to document. But ideally, you're asking at every visit. And then you want to strongly urge all tobacco users to quit in a very clear and strong and personalized manner. For instance, a clear message might be, cutting down while you're ill is not going to be enough. You're not going to rationalize away just a little bit of residual smoking might help me through this bronchospasm. Strong. You want to give them a strong message. I know I know you know that quitting smoking is the most important thing you can do. Well, I'm here to just make sure you understand, to protect your health, that is the most important thing, regardless of my medications or our treatments. That is the most critical thing right now for your health. You can personalize it, tie the tobacco use to their current illness or what's going on in their economic environment. Let them know the impact of tobacco use on children, secondhand smoke in the house. So those are the kinds of things you want to do, is make sure they've heard your message, that it was clear, that it was strong, and it was personalized to them. And once you've done this, you can determine the patient's willingness to quit smoking within the next 30 days. We call this the assessing, whether they're willing to quit or not. If they're willing, you're going to provide assistance. If the patient clearly is unwilling, then you're going to take some time to provide motivational intervention. And this can be relatively easy to do. Take a few minutes and identify the reasons why they should quit in a very supportive manner. You also want to build patient confidence about considering quitting. So you want to plant those seeds of quitting in that patient unwilling at this time. But assisting the patient willing to quit, you move on to 4 pivotal aspects. First of all, we're going to set a quit date. The patient will determine this, and you're going to ask them to remove all tobacco products from their environment, get family, friends, coworker support, review past quit attempts. Think about the challenges they're going to face, including the nicotine withdrawal we discussed, and identify those reasons for and benefits of quitting. So you want to reinforce that as you're discussing the quit date. Next, you want to give tips for success. Ideally, total abstinence is going to be essential. You want to discourage alcohol use. Don't let others smoke in your household. Prior to quit date, maybe avoid smoking in places where you spend a lot of time, such as the workplace or home or in your car. Next, you move on to consideration for pharmacotherapy. You're going to encourage the use of medications unless contraindicated, and we'll talk about those medications shortly. And finally, you're going to provide resources to your patients. On your slideshow, you'll see that there are some websites with free materials, and I encourage you to yourself spend some time at these sites and have your patients go there if you'd like and get free materials that will serve as resources. We'll talk about other resources shortly, but you want to make sure that your patient has plenty of resources, and then you begin to go to the last A, which is arrange. You're going to arrange for follow-up visits. You're going to schedule these visits preferably after the quit date, about a week after the quit date. And the second follow-up contact is recommended usually within the first month. Now, this does not necessarily have to be in person. It can be over the phone or other means, web-based means of contacting and following up with the patient. You certainly want to congratulate successes during each follow-up, but realize that if tobacco use has occurred, your next challenge is to review the circumstances and elicit a recommitment to total abstinence. I think here's where you have a chance to remind the patient that a lapse can be used as a learning experience and identify problems already encountered and then anticipate challenges of the immediate future. You want to assess pharmacotherapy use and how they're doing with it, if they're having any problems or questions with it, and you can even consider referral to more intensive treatments. Now let's talk about practice guideline number 6. Here's where we get into the effective medications based on evidence for tobacco dependence and use, and clinicians should encourage their use by all patients, for the most part, attempting to quit smoking. Now, there are 7 first-line medications. You will see that 2 are non-nicotine replacement. That would be the bupropion and the varenicline, and the others are all nicotine replacement therapy. You can even consider combinations of these, and again, we're going to be talking about that here. So let's just step aside and review some pharmacologic options. First of all, you'll see nicotine replacement. As I said, those are 5 of the 7 evidence-based treatments that we can offer our patients. So nicotine replacement therapy relieves nicotine withdrawal symptoms. And all nicotine replacement products are going to be superior to placebo. We'll look at some efficacy data later. And it will increase quit rates by about 2-fold. Now, the nasal and oral forms of nicotine replacement share a short-acting but rapid onset pattern of nicotine delivery. But in contrast, the patch is going to be longer-acting, slower onset, relatively constant withdrawal relief over a 24-hour period. It takes a little while to reach peak levels, though. So to use any of the nicotine replacement products, you have to pick a quit date. You encourage your patient to pick their quit date and just start their nicotine replacement on that quit date. We talk about a patch plus regimen, which just basically refers to wearing the patch as the primary nicotine replacement therapy and then adding a short-acting form of nicotine replacement as needed to control those cravings and withdrawal symptoms during the day. Now, a few highlights I want to mention about each of these. As you can see, the gum, lozenge, and patch are over the counter. But we do have a couple of prescriptives, the nasal spray and the inhaler. So let's just talk about each of those briefly. The gum should be used in a chew and park manner. And by that I mean that the nicotine is released when you chew. And once that nicotine taste appears, the patient should be instructed to park the gum in their buccal mucosa. And the reason is because they, over the next 20 minutes, will have nicotine levels reach their peak and begin to be effective in the brain. But if they continue to just chew, they're going to begin to have side effects from a large amount of nicotine in the gut, mostly intestinal distress, but they can also have headache, excess salivation, hiccups, even nausea and vomiting. That may also irritate the entire GI system, including ulcers, etc. So it's not a nice thing to get all this nicotine down into the gut. You want to let it be absorbed through the buccal, through the mucosa in the mouth. Now, as far as the lozenge, it's a little bit easier because you can just dissolve it in the mouth for 30 minutes. And the gum, of course, you get rid of after 30 minutes because all the nicotine theoretically is gone. You've chewed, you've parked it, you've chewed it some more, you've parked it. And it's basically like, when you smoke the cigarette, by the end of your time smoking the cigarette, it's gone, you've had your fix, and you can leave it alone for a while. The lozenge, as I said, is a little easier to use. Just let it dissolve, staying in the mouth. You would defeat your purpose if they chew it and swallow it again, getting into a lot of GI irritation. The inhaler is a vapor, of course not a smoke, that's going to be released and deposited into the mouth and throat and absorbed through the oral mucosa. The nicotine vapor does not reach the lungs to an appreciable extent. Instead, it's such that the pharmacokinetics are like the gum. The inhaler addresses not only the physical dependence, however, but also the behavioral and sensory aspects of smoking since they're inhaling. However, the inhaler is available only by prescription. It's important to remember that it can cause bronchospasm, and it may be less appropriate for patients with a history of severe airway reactivity. Finally, the nasal spray. Now, this is the one that gets the nicotine into the bloodstream the quickest and up to the brain the quickest of all of these products. The problem that limits its use is the side effects of nasal and throat irritation, rhinitis, sneezing, and some tearing. So that's the down and dirty on the nicotine replacement products. Let's just briefly mention bupropion that's available as an antidepressant in the United States for the last 20-plus years. And we believe that it works by enhancing central nervous system norepinephrine and dopamine levels. And a sustained release formulation of the drug is licensed as an aid to smoking cessation. We know it as Zyban. It's identical to the antidepressant Wellbutrin SR. It is available in a generic, which is nice. And we see that it doubles the likelihood of smoking cessation in most of our studies. Because bupropion SR takes about a week to reach steady-state blood levels, unlike the nicotine replacement products, you're going to have the patient start your bupropion SR about a week before their quit date. The recommended duration of treatment is 7 to 12 weeks, although if a smoker is successful quitting, the drug is approved for use up to 6 months to prevent relapse. And also, it helps minimize weight gain, which is something that's very attractive to some patients. Now, a potentially serious side effect is seizure. It has been known to decrease the seizure threshold. So a seizure patient or patient highly prone to seizures would not be an appropriate candidate for this medication. And finally, we have varenicline, that is an agonist blocker for the alpha-4 beta-2 subunit of the nicotinic acetylcholine receptor. Now, this is the receptor that's responsible essentially for nicotine dependence. And this medication, we feel, aids smoking cessation in two ways. First, as a partial agonist, it binds to and produces partial stimulation of this nicotinic receptor. Therefore, it reduces symptoms of nicotine withdrawal. The second way that it aids smoking cessation is by binding to this site with a very high affinity. It blocks the nicotine in tobacco smoke from binding to the receptor, and therefore it reduces the rewarding aspects of cigarette smoking for the patient. It's got a long half-life. It's excreted unchanged in the urine. You would want to reduce the dosage for someone with chronic kidney disease. Now, interesting history for this medication. It was fast-tracked in 2006. It showed a 4-time success rate at quitting. More recent double-blind studies found quit rates more like 2- to 3-fold and not necessarily the 4-fold we originally thought. It's possible that higher quit rates can be achieved by combining varenicline with other smoking cessation medications. That includes bupropion and nicotine replacement therapies, both long and short-acting. Preliminary data suggests that combining varenicline with bupropion and nicotine replacement therapy may be efficacious and safe, but we don't know that for sure right now. There are people doing it, but the data is not there. As with bupropion, smokers are instructed to quit 1 week after starting the varenicline, by which time stable blood levels are achieved. And remember that this medication can cause nausea. That will be reduced if they start with those lower doses and go slow, maybe even stay at the lower doses. There is, in addition to nausea, some insomnia and abnormal dreams. But beyond that, we need to look at some other potential safety concerns. Many of you may have seen some of the studies come up over the past year, so we need to talk about those. We have good evidence indicating that nicotine replacement therapy and bupropion are safe for use in cardiovascular disease, even in acute coronary syndrome. We need to remember that bupropion decreases the seizure threshold, so we don't want to use it in patients with seizures. There is, however, the potential for suicidal and other neuropsychiatric side effects with the use of both bupropion and varenicline. Some people are more concerned about varenicline, actually, than the bupropion here. In 2009, the FDA required identical boxed warnings about the risk of serious neuropsychiatric symptoms with both of these medications. Right now, bupropion and varenicline use should be preceded by a careful psychiatric history, and you want to avoid those medications with a history of suicidal ideation or current unstable psychiatric status. Beyond the neuropsychiatric concerns, varenicline also was found recently to impair ability to drive and operate heavy equipment, such that the Federal Aviation Administration, the FAA, has prohibited their pilots and air traffic controllers from being able to take this medication. But the most recent blow to varenicline has come this year when the FDA gave an advisory that it may increase the risk of adverse cardiovascular events in patients with known cardiovascular disease. Now, this was based upon findings of a trial that included over 700 smokers with stable documented cardiovascular disease. And they found a trend toward increased MI, coronary revascularization, and new diagnosis of peripheral vascular disease in the patients on varenicline versus those on placebo. But those differences were not statistically significant. There was also definite efficacy in helping these patients quit smoking. But again, with these findings, and one other finding, that those patients treated with varenicline actually had a lower rate of cardiovascular mortality, but again, that did not reach statistical significance. So we're left kind of wondering with these trends, it helped them stop smoking, there were a few more events, but maybe fewer cardiovascular mortalities. What do we do with this? Well, for now, it is suggested that the known benefits of varenicline be weighed against the potential harms in patients with cardiovascular disease. So do be cautious if you're considering applying these medications to a patient with cardiovascular disease. And the Institute for Safe Medicine Practices described varenicline as now unsuitable as a first-line medication in the treatment of tobacco dependency and use. So maybe we'll see in the next clinical practice guideline that varenicline will move down to a second-rate status. Stay tuned and we'll see. All right, let's see if we can move on to the next slide. Having a little trouble advancing. There we go. So just to touch on, many of you may have heard of other things that people have tried. Nortriptyline is certainly something that has been shown to be beneficial and can be used. Clonidine has limited efficacy. There were some studies showing some improved efficacy for tobacco cessation, but there are side effects such as drowsiness, fatigue, dry mouth that can limit the clinical utility of using this. Cessation, now that is an interesting alternate therapy. It, like varenicline, is a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptor unit. It is a plant derivative. They've used it in Eastern Europe for several decades, but we've not really used it outside that region. Bottom line is currently our experts feel further trials are needed to assess efficacy and safety, but so far it has been received with some enthusiasm. Hopefully we'll see more about that in the year to come. Anxiolytics, I guess of the anxiolytics, buspirone is the one that has suggested a possible short-term benefit and can be used in the appropriate patient. As far as naloxone and naltrexone, these opiate antagonists, we found no convincing evidence that these are helpful. And if anything, amphetamines might increase smoking. And then you have the complementary and alternative treatments, and that's what the CAMS stands for. We have hypnosis, acupuncture. I'm sure there are others. Unfortunately, our studies have found no difference in outcomes at any point in time. That said, we've all seen patients who come in and say, well, I was hypnotized or I underwent acupuncture and I quit. Well, when that happens, you want to encourage and congratulate those patients and not discount what they've experienced at all. But for those who come in and say, you know, I tried it and it just didn't work, and golly, this acupuncture, it just didn't work for me. Well, for those patients, you want to encourage them to maybe consider participating in something that has a better evidence base behind it and move them on to better therapies. On the horizon, as far as therapies, there's this rimonabant that is a cannabinoid-type receptor antagonist. However, there are safety concerns. I'm not seeing that that is going to move ahead. It was used in Europe for a little while, but the sales have been suspended in Europe as of a couple of years ago. So we're probably going to see this fade away. Nicotine vaccine, if you've not heard of this, is a new experimental approach to treating tobacco dependence. And this vaccine would cause the body basically to generate specific anti-nicotine antibodies that would bind to nicotine that reaches the bloodstream from smoking cigarettes. The result would be that the nicotine antibody complex is too large to cross the blood-brain barrier, and therefore that nicotine that is derived from tobacco smoke is unable to reach the central nervous system nicotinic receptors to produce that reinforcing effect of smoking. So theoretically, as the smoking becomes less rewarding, the smoker is more likely to stop. Certainly we need more clinical trials to know about this vaccine and if it's going to fly. Let's move on to our 7th clinical practice guideline that reinforces the notion that while counseling and medications are effective individually, it's the combination that's going to give us the most bang for our buck. So we need to encourage all individuals to make a quit attempt and to use both counseling of some sort and medication. Now, I told you earlier we would look at some statistics regarding the efficacy of each of these therapies that we have discussed. And this is at least some 6 months post-quit data that we have. And you can see that placebo at 6 months hovers somewhere around 13% for successful abstinence at 6 months. Now, if you come on down to varenicline, you'll see about 3 times the quit rates at 6 months, sustained quit rates. Come on down to bupropion, and it's 24%, so about twice what an unaided quit attempt might yield at 6 months. Here are some combinations to look at. I want you to see the Patch Plus. We talked about Patch Plus. So here's Patch and here's the Plus, a short-acting for the cravings that they might have. Look at this, pretty effective. And that's not even pulling out our varenicline or our bupropion. And then we have other combinations. In general, the SSRIs are considered ineffective except for what we've spoken about, and we already mentioned the fact that these medications are not going to help us out. And you can just scan this. Here is nortriptyline, again, better than placebo. So there are some good data to support use of these medications and combinations. Our 8th guideline reminds us that quit-line counseling is particularly effective to lots of patients, can be effective specifically with adolescent smokers is one thing that we're finding out. So don't forget your quit lines. Every state has one now. In Clinical Practice Guideline 9, it reminds us to use motivational treatments. We alluded to that earlier. When you have a patient unwilling to quit at this time, you want to identify why they should quit, why they should consider quitting, and then you want to build confidence about their ability to quit. You can give them some truthful statistics, such as the average smoker loses an estimated 12 years of their life due to complications from smoking. You want to assure they know that smoking increases the risk of many types of cancer, heart attack, stroke. And maybe for the guys, don't forget to try this one. And it's, again, truthful statistics show that smoking increases risk of erectile dysfunction. Maybe that will get them where it counts. So, motivational treatments and discussions. And I want to show you, would like to show you one of these YouTube videos that you may be able to link into on your own computers. It's not pulling up for us right now in this common session, but feel free to go to the website below on this slide. And I like this because it talks a little bit about certainly some patient education. It was actually created by a high school student for one of their own classes, but put it on YouTube, and it's actually a fairly good documentary showing some patient education that would be very applicable to adolescents, young adults, and even kids. My own child watched this video and said, "Ooh, Mom, I'm never going to smoke." So you can refer your patients to these videos. This shows lung cancer. It shows diseased lungs. It talks about all the harmful chemicals in each tobacco stick. It shows a lot of visuals that will reinforce the notion that they are literally killing themselves with tobacco. So just refer them to some of these web-based sites. Tell them to look up the harmful effects of smoking. And again, when you get a chance, I encourage you to look at this website. So how are we doing? Well, in the past 40 years, the ratio of current smokers to former smokers has actually reversed, and that's encouraging news. Our view as a society has changed. We're not calling it just a habit, although that is a component of it, but now we're seeing it as a chronic relapsing disorder. Tobacco use assessment and intervention are considered to be very key components of good clinical practice. And there are a lot of effective treatments. We have a lot to offer our patients now that we never did before. And as I mentioned earlier, every state has a quit line. And the FDA is putting their money where their mouth is, so to speak. They're planning on focusing about $600 million over the next 5 years to educate the public about the dangers of tobacco use. They're hopeful that the first campaign will coincide with new graphic warning labels that should appear on cigarette packs by this coming September 2012. And these labels will include images of corpses of dead smokers and diseased lungs, smokers wearing oxygen masks, and a man wearing an I Quit T-shirt. And there's going to be large-scale national studies of tobacco users so that they can monitor and assess behavioral impacts of tobacco regulations that are being put out. Finally, number 10, since tobacco dependence treatments are both effective and cost-effective, the guidelines suggested that increasingly we should see more coverage provided for these treatments. And we've seen the trend happen over many decades, and especially the last decade, where increasingly our patients have access to covered benefits and medications for the purpose of tobacco dependence. The American Academy of Family Practice Tobacco Cessation Advisory Committee did some research, and out of that research, they have come up with an initiative that challenges family physicians to ask and act, essentially the 5 A's, but you can boil it down to ask and then act on a patient's tobacco use. And they have provided this toolkit that you will be able to click on. If you see this slide, click on each of those, the toolkit, office resources, patient education materials, and continuing education. I also want to mention that payment for tobacco cessation counseling, the status at this time, Medicare currently pays for tobacco cessation counseling for patients who use tobacco and have a, quote, disease or an adverse health effect that has been found by the U.S. Surgeon General to be linked to tobacco use, end of quote. So again, when you get a chance, I'd like for you to click on this toolbox. It will be constantly updated, and it's to encourage us to ask and act and to facilitate our ability to carry this out in our own practices. So please check that out. And basically, when you are giving your tobacco cessation counsel to your patients, you're going to want to take into account history, the type of tobacco they're using, medications used in prior quit attempts, and their readiness to quit, like we talked about. You'll come up with an assessment and plan that includes the quit date, counseling that you've given, and handouts or resources that you've provided. The pharmacotherapy that you might use should be documented, and when the follow-up will occur and how, if it's going to be over the phone or just how that will occur, is something you want to make sure you document. We know that for meaningful use, we talked about core measure 9 of the 15 core measures. Well, here is a template that you can, again, click on this slide, and you will find a template that will go over some of the basics for integrating tobacco cessation into your electronic health records. So as we close, we want to look at what's next. Certainly we know we need more consistent and innovative and effective interventions and options for use in certain people groups. Now that we've been addressing the broad problem, getting into certain people groups, for instance, there are American Indian groups where the prevalence of tobacco use is greater than 30%. Now, compare that with our country as a whole at around 20%, 21%. So we've still got a lot of work to do, and coning it into specific people groups is going to be one of the next challenges. There will need to be new research to examine the results of implementing these in a real-world setting. And increased consumer demand is hopefully, through public education, something that will be created for more effective treatments. And I'd like to close with a statement from Dr. Don Berwick's recent farewell speech as he addressed the Institute for Healthcare Improvement. What is truly important is this: to help the people who need our help the most. We want to recognize these people clearly, who they are, and how we can help them is the challenge. So it has been my pleasure to have this time with you talking on tobacco cessation. I encourage you to look at the resources contained within this PowerPoint, and if there are any questions, Susan will be happy to take them now.
Well, we actually do have a question, Dr. Crossman, and it's specific to kind of your area of expertise, but consider that you have a pregnant woman who has some medical background. She is, though, however, smoking. how would you counsel her to quit smoking, and then would quitting reduce her risk for developing gestational diabetes?
You know, that's a wonderful question, and I actually know that in the short term, the benefits definitely outweigh and lean toward counseling her to quit. So I'm going to spend time with Rosita talking about specific tailored messages. If she is, first of all, is she willing to quit? I may not need to spend that time, are you wanting to quit? But if she's not willing to quit, or if she says, you know, I just don't think I can, which is the conversation we mostly hear. I've tried it before. I quit the last time I was pregnant, and then I started smoking again, and so I'll probably do it this time, but I don't even know it's worth quitting right now. Well, I'm going to talk with her specifically about the increased rate of SIDS, the complications for this pregnancy for her baby in the immediate future. And then as far as her gestational diabetes, I think I heard something about with her medical background of gestational diabetes. Clarify if I heard that correctly?
Yes.
Okay, so with a history of gestational diabetes, you know, there is one little concern here, and that is the potential for weight gain. And Rosita may be very concerned about that, especially if she's starting out already overweight. Well, gee, Dr. Crossman, if I stop smoking, I'm going to gain weight. And that is a patient that you might consider, if she's psychiatrically stable and has no history of seizures, you might consider bupropion, even in the pregnancy, because that does seem to abate some of the appetite increase that some people will experience when they stop smoking. So that's a patient that I might have a discussion about bupropion, because if she gains weight, her gestational diabetes will certainly come on, but we can manage that diabetes far better than the complications of the tobacco if she has ongoing smoking. So I hope that answers that question.
Very good. Thank you. That does bring us to the end of this particular webinar. As you know, this is an ongoing series with a variety of topics. Those topics are all, the webinars are all recorded and will be available eventually on the website www.godiabetes.org. And with that, thank you so much for your time and attention, and we'll look forward to having you participate the next time.
Very good. Our pleasure.